Thank you so much. I'm happy to talk to you about influenza in children with medical complexity. I have no financial disclosures, and I don't intend to talk about unimproved programs or unimproved uses, but if I do, I will try to remember to tell you that. Next one. So, as you know, during COVID-19, everything is changing so quickly that I need to give this disclaimer pretty much every time I talk, because some of the information that you hear will be out of date relatively quickly. And these are the websites for the best up-to-date information. Next slide, please. So what I'd like to do today is to provide you an overview of influenza and discuss considerations for influenza and COVID-19 during this upcoming fall season. And we also want to talk about planning for influenza vaccine administration. Next one. So this is just a chant from 1918, and it said that the chant was, I had a little bird, his name was Enza, I opened the window and influenza. Just a kind of a cute way to start the presentation. Next one, please. So influenza viruses or orthomyxoviruses, the two types that affect humans are type A and type B. Type C is an occasional cause of human disease, but not very common. We know that every year we have outbreaks of A and B, and the reason is because the neuraminidase and the hemagglutinin on the outside of the virus changes, it drifts and it shifts, so that each year a somewhat new strain of influenza virus circulates, and you're no longer immune to that virus, so you can get influenza over and over again. Next slide, please. Now, there have been several pandemics of influenza, and I think everyone's familiar with the 1918 flu, which was the worst one. The most recent one was 2009 with H1N1, a relatively mild pandemic. But as you can see, we're kind of due for the next influenza pandemic. So hopefully, it won't occur in the near future. Next slide. So you're all familiar with the illness influenza, and as we look at these symptoms, think about it. Fever, chills, cough, runny nose, body aches, malaise, headache, myalgia, fatigue, and in younger people, vomiting and diarrhea. It sounds just like the symptoms of COVID-19, and unfortunately, they are similar symptoms. However, in children, these symptoms are more likely to signal influenza because remember, many or most children with COVID-19 have few, if any, symptoms. As far as signs, what do you see on examination? The child will have fever, sore throat and a red throat, rhinitis, and cough. And remember that if you get the vaccine, although it may not prevent disease, it will modify the illness. So the illness will be much milder in immunized people. Next one. What's the epidemiology of influenza? Well, we know that these occur in winter outbreaks. And we always used to think, well, where does it go in the summer? And, you know, it goes to the southern hemisphere, but we also now have had these cruise ship outbreaks. And these, interestingly enough, have always been during the summer. So it takes a break during the summer or it goes to the other hemisphere. The epidemiology of influenza is very different from that of COVID-19. We know that for influenza, children have a major role as the transmitter of infection. We also know this virus, like COVID-19, is spread by droplet and sometimes contact spread, so the use of fomites. You're contagious with influenza for a day before you get symptoms to 7 days after, and the incubation period is very short, only 1 to 3 days. So this rapidly goes through a family. Next one. The role of children with influenza transmission is really great. Why? Because they have the highest attack rates. Every year, 15 to 42% of children are infected with influenza. They also have the highest hospitalization rate. Fortunately, they don't have the highest mortality rates, but they end up in the hospital because they can look very sick. They are the major transmitters of influenza because it's the first time or only the second time they're having the disease, so they shed higher viral titers for longer periods of time. Further, they don't have so much control of their body secretions. They're very happy to share their nasal secretions with you. They may not want to share their toys, but they're happy to rub their nose and share their snot with you. So that's the way that children spread the disease. And look at this child being held by the mom. See how close their faces are? Anything that child has, she's going to give right to that mother, and vice versa. Next one, please. So this is a review of some of the influenza seasons. And I want you to look at the one in red, dark red. And this is last year, 2019 to 2020. And what you see is a peak early on in the December range, and then a little bit of drop off, another peak in February, and then this other peak. This is influenza-like illness, and almost certainly that peak actually represented COVID-19. And really, the symptoms are indistinguishable. Next one. This is a slide that the CDC puts out weekly, and it shows you where there is influenza in the country. And this is actually influenza-like activity. So these are the symptoms of influenza. Might not necessarily be influenza. But what you can see here is almost all the country is green, except for Puerto Rico, which is having some increase in the influenza-like activity. Next one. And you can look at this every week, and you can see what's happening throughout the country with influenza-like illness and influenza. Next slide, please. What are the complications of influenza? We get either from the virus itself, viral pneumonia, or bacterial superinfection, and that is mainly in the lung, bacterial pneumonia, with things like pneumococcus, Haemophilus, the usual suspects, but also Staph aureus. Staph aureus and influenza together are a bad mix and make for severe bacterial pneumonitis and severe bacterial pneumonia. We know that asthma is triggered by influenza. We also know that influenza, particularly type B, gets to the muscles and gives a lot of inflammation of the muscles, or myositis. And then both A and B can cause inflammation of the brain and encephalitis. Next slide. These are the pediatric deaths associated with influenza. And you can see it varies by year, but every year we have more than 100 deaths in this country due to influenza. These deaths are in children with normal immune system, as well as in children who have immune problems or are receiving therapy that puts their immune system at risk. The other thing to note about this is 80% of children who die of influenza have not received an influenza vaccine. Next slide, please. Now, how do you make the diagnosis? Well, if you're in the middle of flu season, usually it's just clinical exam. The child comes in with fever, sore throat, aches and pains. That's enough to say this is likely to be influenza. This year, it's going to be a little more difficult because we're going to have COVID disease in the background. You confirm the diagnosis by culturing of a throat or nasal swab. Culture is rarely done now. Usually we go to antigen detection or PCR testing. Antigen detection is rapid, but it's not nearly as sensitive as the PCR testing. So rapid antigen detection can be as insensitive as only 50%. PCR testing is 90 to 95% sensitive. And serology here for influenza is not really useful because it takes you 2 weeks after the patient's already recovered to show that they had the disease. Next slide, please. How do we manage influenza? Well, there's a lot of symptomatic management, and this is giving people things to make them feel better. But I would remind you, aspirin should never be given to children because of the association with Rye syndrome. And antipyretics such as acetaminophen or ibuprofen may actually prolong viral shedding. So you're taking away the body's ability to fight viruses. So you don't really always have to grab for that antipyretic. There are a ton of complementary therapies, from elderberry to everything that you can think of in your health store foods. Elderberry actually looks like it does have some clinical evidence that it may be helpful. Zinc, lots of people use lots of complementary therapies which have not been proven. My favorite complementary therapy is what my mother recommended, and that was a small glass of scotch. I do not recommend that for children, but sometimes their parents might benefit from it. And we do have antivirals for influenza, and I'm going to review those quickly. Next slide, please. The benefits of antivirals. Children will benefit from antiviral treatment when it gives them a clinical benefit, there are minimal side effects, and it's cost effective. So what do we have? Next slide. We have several antivirals. The neuraminidase inhibitors are the ones you're most familiar with. So oseltamivir, which is given by mouth, zamanvir, which is inhaled, and now peramivir, which is given by IV. Peramivir, although you would think it's IV, so maybe it's for inpatients, it's actually only approved for use in outpatients, hasn't been studied enough in inpatients with severe disease, and it's a single dose. When might you use it? Well, in children with medical complexity who can't take an oral medicine or an inhaled medicine, peramivir may be exactly what would be beneficial. Next slide, please. The newest antiviral is an antiviral called baloxavir, and this has a new method of working. It's an endonuclease inhibitor, and it blocks transcription of the influenza virus RNA. It has been approved for use, but only for children over 12 years of age. So no approval under 12 years of age. And its benefit appears to be greater for B than it is for A. And again, this is a single dose medicine. Next slide, please. Antivirals should be used in people who have suspected or laboratory confirmed diagnosis of influenza. If they're at high risk of complications, you don't care where they are in terms of their symptoms. If they've been sick for 5 days and they're just now coming to you, but they're at high risk, they should get an antiviral. Hospitalized children should get an antiviral. And those with severe, complicated, or progressive disease should get an antiviral. Next slide, please. You should consider treatment also in otherwise healthy, symptomatic children who have been sick for less than or equal to 48 hours. And this is particularly true if there are people at home who are at higher risk. So if they have contacts who are under 6 months of age or have medical complexity, those are the patients that you would like to treat so they don't give it to their siblings. Next one. Remember, for antivirals, the antivirals for influenza only work for influenza. They're not active against other respiratory viruses. They're not active against SARS-CoV-2. Remember that an antiviral study looks at the effectiveness of therapy for all influenza-like illness, so you may not get the answers that you think. When you use antivirals, please be reasonably certain you're treating influenza. Don't give higher doses than are recommended. There's no benefit in higher doses or prolonging therapy in normal hosts. And we think that adjuvant corticosteroids are probably harmful for influenza. Next one. Well, we'd rather prevent influenza than try to manage it. So how do we prevent it? Important to do infection control, isolate the patient from others, wash your hands or use the hand sanitizers. Respiratory hygiene is you cough into your sleeve. Sometimes you use the sleeve to get your nasal secretions. You're trying to keep the virus off your hands. Now that we're wearing masks, respiratory hygiene is not so much important. Limiting visitors is important, that visitors aren't bringing in influenza. Distancing, physical distancing works for influenza, and the same personal protective equipment, masks, goggles, gowns, and gloves. Vaccines are available for influenza, and we're going to talk about them next. And then chemoprophylaxis also works. If you've been exposed, you can take an antiviral to prevent disease. Next slide. There are several inactivated influenza vaccines. Each year, the composition is altered. And this year, for children, it's all quadrivalent. So 2 A strains and 2 B strains. Both A strains are new, and one of the B strains is new. It's a split product, so that it has less side effects. There are no adjuvants in children's preparations. So there's no aluminum hydroxide in any of the children's preparations. There are many licensed. They're all age specific. So you just have to use what's appropriate for the child that you're immunizing or the adult you're immunizing. Next one. The recommendations are that everyone 6 months of age and older receive an influenza vaccine. And for the inactivated vaccine, it can be any one of the products as long as it's appropriate for that age group. We really want to target high-risk people, and we believe that mandates are appropriate for healthcare providers. All of us should be immunized, and we should all be immunized by the end of October. We also want to immunize pregnant women to protect them and to protect their infants. Next slide, please. What about the live attenuated vaccine? This is a spray in the nose, so it's many children would prefer it. It's a cold adapted virus. It doesn't survive body temperature. It's immunogenic, it's safe and rarely transmitted. It was approved way back in 2003, and originally we thought it was actually going to be more efficacious than the inactivated vaccine. And so it was recommended to use either or. However, in 2016 and 2017, the product just didn't work well, so it was not recommended for general use. In 2018, again, it was starting to be used, and since 2019 and again this year, it is okay for use. So if you have a child who is in the right age for live attenuated, has no contraindication, you can either use that or the inactivated vaccine. Next one. So the recommendation for live attenuated influenza or the flu mist is healthy people between the ages of 2 and 49, and it's not for use in the very high-risk people. Those are considered precautions, and in some patients, if you're truly immunocompromised, it's a contraindication. It is okay for healthcare providers and for family members unless their contacts are severely immunosuppressed. So that would be a brand new bone marrow transplant. But minor suppression, no, you can still use this because, again, there's very little transmission. Next slide, please. Well, what's the schedule? So we're going to start giving the vaccine as soon as it becomes available in the offices, and we're trying to get everybody immunized by October. Remember, everybody 6 months of age and older without a contraindication should be immunized. For children 8 and under, you need 2 doses during the first season. If you're 9 and above, just a single dose is necessary. If you have egg allergy, this is no longer considered a contraindication. There are some egg-free products for older ages, but all of the products for pediatrics do not have enough egg in them for it to be a problem. Next slide, please. Now, what about vaccine efficacy? We hear all the time, oh, that vaccine doesn't work very well. And in fact, as far as absolutely preventing influenza, the vaccine is generally between 30 and 60% effective, not nearly as effective as we would like it to be. And we know it's age-related. It's less effective in the very young usually, and less effective in the elderly, which is why there are special vaccine made for older adults. Now, even though it's only 30% to 60% effective at preventing influenza, it modifies disease in those in the breakthrough cases. So it may not prevent disease, but it's going to attenuate the disease. So it protects you from hospitalization and from intensive care stays and from death. So particularly for our medically complex patients, we don't want them in the hospitals. We don't want them in the PICU, and we certainly don't want them to succumb to influenza. So we really want to get everyone vaccinated. Next slide, please. Chemoprophylaxis is giving the antiviral to someone who's been exposed. Oseltamivir is approved for this use in people over 3 months of age. Zamanvir is approved for ages 5 and above. And when would you use it? You'd use it in patients who you're unable to vaccinate or you don't think they'll respond, or while you're waiting for a response. You might use it in a scenario where there's a high-risk patient and it's a vaccine mismatch. You could use it in an outbreak in a long-term care facility where you may not be able to get everybody immunized and everybody's been exposed. And you should consider it for close contacts. So in your family with complex disease, with the child with medical complexities, If their sibling develops influenza, you can prophylax the child with complex medical needs to prevent them from getting influenza. Next slide, please. Well, what about COVID-19? It is definitely going to be circulating at the same time that influenza is circulating. We know that COVID disease is generally mild in children. We also know that co-infections with COVID have varied dramatically. In some studies, as little as 2%, but in other studies, more than 20%. And in one study, more than 50%. So co-infections vary. So just because you have influenza doesn't necessarily mean you don't have COVID. But again, the influenza for children is probably going to be the more severe disease. What we don't know is if you have both viruses, will your illness be more severe? Next slide. Let's talk about COVID versus influenza. So the clinical illness, we said it's worse. Influenza is worse for children, for most children, than COVID-19. For transmission, adults are the ones generally spreading SARS-CoV-2, the cause of COVID-19, whereas children are clearly the transmitters of influenza. Influenza incubation time is much shorter than COVID-19. So it's 1 to 3 days versus the usual of 5 to 6 days for COVID-19 and up to 2 weeks. The diagnosis for both PCR tests are clearly the most sensitive, much more sensitive than antigen detection tests. And as far as treatment goes, we have proven treatment for influenza. We have less clear treatment options for COVID-19. Next slide, please. What about prevention? Well, this is the good news. All of the things we've been doing to prevent COVID-19 from spreading will also prevent influenza. So wash your hands, cough into your sleeve, or wear a mask, physically distance, and for healthcare providers, wear the appropriate protective equipment, including masks and goggles, to prevent you from getting sick. That protective equipment also keeps you from rubbing your eyes and touching your nose, so it protects you from self-inoculation. And that's been shown to work for respiratory syncytial virus as well. What about vaccines? We have a vaccine for influenza now. We will have a vaccine for COVID-19. When it would be available for the general public isn't clear, but we think we will probably have a vaccine by the end of this year or early in the next year for many people. Clinically, can you tell COVID-19 from influenza? Maybe. There are a couple symptoms that are classic for COVID-19 that don't happen with influenza, and that is loss of taste or loss of smell, but those are uncommon in children anyway. So maybe you can tell them apart, but likely you're not going to be able to tell them apart. So our state health department data and our local health department data are going to be very helpful because they'll be able to tell us when influenza is in our communities. And you can go to that CDC website to see where influenza is in the entire country. Next slide, please. These are resources that we've gotten together for you, and you can go to these anytime. A lot of good information from the AAP and from the CDC. And remember, for your families, healthychildren.org is a great resource. I'll end there and be happy to take any questions.